Okay, we're going to go ahead and get started. For anyone who's on the line that I haven't had the opportunity to meet, I'm Mindy Clouden, and I'm the Director of Strategic Initiatives at CBHC. And we really appreciate you taking time out of your busy schedules to join us today. So we are about a year out of the end of the State Innovation Model, or SIM, and we thought that this would be an ideal time to look back and reflect on some of the lessons learned from SIM, take a look at what some of the successes were from the program, and see what we can be learning from the 4 mental health centers that participated, and also just take an opportunity to show off some of the new materials that we have developed for you all to use for the 4 centers, but also for all of our members. We'll talk a little bit about how we might be able to leverage some of the successes and some of the information that we're sharing today with you all. So for those of you that were not familiar, the State Innovation Model was funded by the Center for Medicare and Medicaid Innovation, or CMMI, and the state of Colorado had the opportunity to apply for a $65 million grant that was to support the state in doing some innovative work to look at strengthening the healthcare delivery and payment system. About 6 years ago, when this application was being worked on, George Del Grosso, who many of you know, who at the time was the CEO of CBHC, reached out to me and said, you know, we have an opportunity to be included in this. And we know that it's so important that community mental health centers are recognized as an appropriate healthcare home for people that have serious mental illness, serious emotional disturbances, or substance use disorders, that we know that many of the folks coming through our doors don't have primary care anywhere else, and many of our members are doing integrated care. And so we want to be sure that we're included in this opportunity. And so we put together a proposal in just about a day that got wrapped into the larger proposal. And then CBHC had the opportunity to select 4 community mental health centers to participate in this work. The 4 that were selected through a competitive application process were Community Reach Center, Jefferson Center, Mental Health Partners, and Southeast Health Group. And these 4 centers were given some grant funding and some technical assistance to further their bidirectional integration or work on developing integrated health homes. They found that over the course of 4 years that many operational adaptations were needed. And in the summary report, which we sent out as part of the invitation to this, and which we are now making available to you all, we summarized some of those changes that were needed, including ways to adapt the workforce, additional kinds of training opportunities that were needed, changes to administration, clinical operations, financing, and more. We found through SIM that community mental health centers really do play a critical role as health homes, and that the folks that were coming through the doors of the 4 centers were really able to demonstrate important improvements in healthcare for their patients, and also were able to break down barriers to care that had existed previously. By offering integrated care, they broke down stigma, transportation barriers, and other things that were getting in the way of folks accessing primary care and whole health services. So some of the notable accomplishments that the 4 centers achieved, and these were things that were noted by the evaluators of the State Innovation Model. So these are not just things that we as CBHC or as the 4 centers put forward, but were really found objectively to be notable accomplishments, were that the clients that were served through the 4 centers demonstrated notable health improvements. Those occurred in both behavioral health realms and in physical health realms. So the CMHCs reported that they had a reduction in overall symptom severity for these patients. They had improvements in depression screening and management, improvements in hemoglobin A1C screening, which we know is critical because there's such a comorbidity with folks with serious mental illness and diabetes. All 4 centers showed a notable improvement in their integration scores. In fact, this was even higher than what the primary care practices were able to achieve. And through the technical assistance and data reporting that they were required to do, the 4 centers also demonstrated an increased ability to be able to report on clinical quality measures, to use and apply data for quality improvement, and to exchange health information. This is all really critical when you think about participating in value-based payment models, sharing information with partners across a community and across a healthcare neighborhood. Another really significant achievement is that through the Milliman cost study, Milliman being an actuarial firm that it works nationally but also has an office here in Denver, we found that all 4 participating community mental health centers demonstrated a significant return on the investment of CMMI and healthcare savings across all payers, commercial, Medicaid, and Medicare. So this is something to really be proud of and to tout. So a little bit about kind of what these 4 centers and also other CBHC members might think about in terms of how to use this information. We really want to encourage you to leverage this information, and particularly the lessons learned that are spelled out in the report, to help support new employee orientation and training efforts around integrated care. We also want to encourage you to use these to help promote any new integrated care partnerships or strengthen the work that you're already doing in your community with integrated care partners. And then also to think about if there are ways that you can leverage these outcomes to help support development of your value proposition, whether that be for payers, your RA, Medicaid, foundations, private insurance, or other work that you're doing to garner local community support. So I've kind of laid the foundation. What we're going to be doing now is I'm joined today by presenters from each of the 4 community mental health centers. From Community Reach, Jill Atkinson. From Jefferson Center, Dr. Shannon Paletti. Mental Health Partners, Sarah Reed. And from Southeast Health Group, Dr. JC Karika. And I'm so honored that each of these folks took time out of their busy schedule to be with us today. What I've asked them to do is to think about and respond to each of these 3 discussion questions. I've asked them to think about, as they look back on SIM, what impact did their participation have on their clients and their community? Now, SIM ended a year ago and much has changed. So what does it look like now? What have you been able to sustain? And what does integrated care look like for you now? And then also, how do you see integrated care fitting into the future of the work that we do as community mental health centers in Colorado? So I'm going to step aside and ask the 4 folks to be ready to jump on their screens. This is where you can get more information and some of these beautiful materials. We have the report, we've got a PowerPoint you can use, we've got inserts from each of the 4 centers and sample blogs. You can reach out to me at any time. There's my contact information. And I'm going to go ahead and stop sharing my camera so folks can see the presenters. And Sarah, I'm going to call on you first because you're showing up first on my screen. Go ahead, Sarah, it's all you.
Hi, everyone. Well, thanks for letting me kick it off, Mindy. It's good to see you all. This feels like a blast from the past because I'm saying things have changed is an understatement. But what I want to start with is how I think that the Integrated Health Home at Mental Health Partners has sustained, because what's top on my mind lately, as I'm sure for all of you, is COVID. And our work during the 4 years of SIM, I think set us up for success in a lot of ways to navigate the times we're in right now. And that sort of, I think, provides a good overview for how we got here and how how we're still working. So our integrated health home is at the Ryan Wellness Center in Boulder, and as a partnership with Clinica Family Health and Dental Aid. Over the last several months, our teams have been working really closely with both Dental Aid and Clinica Family Health. And Clinica is just now starting to bring back in-person services after having to end those for a bit because of COVID. And the team's been working really hard on teledentistry services. And so I say that now as kind of the snapshot of where we are right now. And it took a lot to get there. And our 4 years of SIM was a huge part of that, obviously. I think we started out with a really strong shared vision across leadership and across the on the ground clinical team. We all knew what we wanted to do and certainly had different ideas on how to get there, and took a lot of creative thinking. But it worked because everybody knew what the end destination was going to be, and that was going to be improved integrated care for adults with serious mental illness and chronic comorbid conditions. And one of I think the best examples that illustrates the creative thinking and the kind of different ideas of how to get where we all wanted to go is around our group intervention model. So Mindy talked a little bit about A1C and the prevalence and struggle of diabetes for a lot of the clients we serve. So that was our first effort during those first 4 years of SIM, was looking at, from a population health perspective, what are some of the conditions that cause the most stress and struggle and subpar health outcomes for our clients, and A1C and diabetes was one of them. So what we did was some really interesting data sharing and analysis with Clinica to look at clients with consistently high A1Cs over time, and we identified them for targeted outreach to say, would you like to try out this new group intervention model with us? And it took a lot of time and a lot of meetings and a lot of collaboration to figure out how to make it work, because MHP had a group intervention model, Clinica had a group intervention model, and getting those to work together in one cohesive way, it took effort. And so we tried a lot of things over the course of probably a year in terms of who would facilitate and how the Clinica PCP would be involved. Lots of stops and starts and CQI type approaches to figure out what would work. And finally, we landed on something that was pretty new. It kind of incorporated the best of both MHP group model and Clinica group model, and was overall pretty new for both centers, where the PCP would join a couple times a month, and the group really focused in on whole health. And that was something that really helped us kind of understand and help these clients and what they were going through kind of out of the context of A1C. And that since has kind of spurred lots of other similar group interventions, like for chronic pain and those kind of things. And, you know, I give that one as an example because going through something like that and trying to align workflows that were so different, really it showed every step of how leadership and direct service clinical team were committed to doing something. And it's, you know, it was very specific work, and we did that in a lot of different areas. So, you know, and I think that was one of the pieces to answer that first item on impact, and how we think it's impacted our community. That A1C group example demonstrates just the level of coordination and collaboration it took to deliver this kind of service as a new way of thinking. And we created a series of work groups and had lots of meetings and emails, and became very close buddies through development of this work. And it was things like the A1C group that really came out of it and have endured over now several years. And so I think that's been one of the biggest pieces of impact. And I think, you know, on the sustainability front of what we've been able to sustain, that we've kept in-person dental services was pretty huge, and in-person primary care partnerships. So Clinica team comes over, well, pre-COVID, came over to the Ryan Wellness Center and provided care all in one physical space. That was a huge shift from how we were functioning before. And then, like I say, really set us up to be able to navigate something as complicated and impactful as COVID. That the clinical team from MHP staff, dental aid staff, Clinica staff, all still were in touch. And even though there were certain logistics that, obvious logistics that prevented Clinica from being able to see clients in person, the MHP staff were still able to stay in touch with the Clinica nurse and other folks on the Clinica team to still follow up because while we couldn't see clients in person, they still needed care and they still needed help and coordination. And so they were still able to do that via phone and email. And it was kind of a product of that shared commitment to the vision. And then, like I say, they're able to, we're starting to phase back in the in-person services slowly. And so I think where we see it going in the future, at least for us at MHP, our work with SIM was a really important step toward where we are now, which is in the second round of our CBHC grant, the Certified Community Behavioral Health Clinic effort through SAMHSA. And it set us up for success in a lot of important ways to be able to think about care in a different way, value-based payment models, value-based care, and what does that look like? How do you really create workflows and policies and functions to treat a whole person in a really integrated, well-coordinated way? And that's a big part of the CBHC effort, which I don't think we could have done quite so well without this first step over the 4 years of SIM and a lot of the technical assistance and collaboration we got from working with the other 3 centers and learning from each other over those first 4 years. And it helped us, even think about more logistics like holding daily huddles. Our integrated care, integrated health home held daily huddles. And that was very different for MHP staff. Clinica staff knew how to do it. They had it down to a science, but it was really new for behavioral health staff. And what we learned from that really helped us broaden that out and have other clinical teams hold daily huddles, which just made care that much more coordinated and helped different roles on the teams really talk to each other. So there were a lot of very broad ways that it set us up for success, and then lots of specifics like the group model and daily huddles and that sort of thing. And Mindy, I have not been paying attention to the clock. Am I okay on 10 minutes?
You're just right on 10 minutes. That was perfect.
Perfect.
Was there anything else that you wanted to share?
I don't think so. I mean, I'm always open to questions, and I have the chat box open. So if anybody has questions on anything I rambled about, please let me know. And like I tell Mindy and Tony Moon and Jen and Dixie all the time, is I will talk about our integrated health home for days. It's, I think, one of the most important and impactful programs that I've been involved in my career. So I will talk about it for hours and hours. So before I do any of that, I'm going to cut myself off at 10 minutes.
Great. Thank you so much, Sarah. And as Sarah indicated, feel free at any point to put some questions into the chat box. We'll also let you unmute your phones towards the end to ask questions verbally if you want to. I'm going to go ahead and call now on Jill, if you're ready.
All right, there we go. I am back. So our collaboration was between Community Reach and Salud, and they put a physical health practice in the middle of one of our outpatient offices. And and I think throughout the course of SIM, we learned quite a few valuable lessons, and I think the most important thing that we learned how to do was how do we talk to clients about their health and how their health is connected to their mental health and how their mental health is connected to their physical health. And that if we're not able to talk about both together, then neither one is going to get significantly better. And I think we learned that that can happen on multiple levels. So the peer support team was critical in running whole health action management groups and incorporating healthy living activities as part of being the peer support team. And so really looking at and understanding every person who has contact with our consumers can have an impact on their overall health and wellness. And so then moving forward, what we did is we have kind of thought more broadly about integrated care. And in our other offices where we don't have a PCP embedded, how do we improve communication with PCPs and with other health organizations? Because we've got consumers who are seen, all over the Front Range, and being able to understand and to have information about their health is beneficial to us. And then in our communication back to PCPs is super beneficial to them to know what we're doing and what we're prescribing. And then I would say the other piece that was super helpful about SIM was understanding CQMs, and even though they were hard to produce and difficult, it really lined us up for other initiatives that require it, like the Medicare MIPS program, where we have to report on CQMs. And so again, it really kind of helped us pivot to a place of being able to capture health information in our own EMR, and then set us up for being able to report it out, and in a way that is meaningful to larger systems like Medicare and to Medicaid. And I think that from our consumers' perspective, the the improvement in just focusing on overall kind of health and wellness, and to be encouraged to, we have lots of therapists who now take their consumers for a walk in the open space across the street from our office. For instance, when we're not in the middle of COVID, at the moment, most of our groups are now online, but when we're in person, it's what can we do that incorporates health and wellness in everything we do. And, if we can take people for a walk, if we can encourage them to, incorporate one healthy activity in their life, then that translates into overall improvement. And and I think that the other piece was it really improved our focus on outcomes. So PHQ-9 outcomes, HRQOL outcomes, audit outcomes, and that was a change and a shift that we had not implemented or thought about previously. And so I think that was another really a valuable experience from participating in SIM. And I'm watching my time. Mindy, am I good on time?
Yep, you're good.
Okay, because you know, I think that the future of integrated care or the future of behavioral health is integrated care. And I think that the ability to be able to talk to consumers about their A1C and about their weight and about their blood pressure, and to be able to make some headway on those issues, I think that's the way the system is going to have to work in order for us to do the things that are being required of us, which is all about controlling cost, improving outcomes, right? The triple aim. And I think that the other big learning for us was just how uncomfortable our clinicians were at the outset on having those conversations about A1C. Like, some of them couldn't even tell you what an A1C was, let alone what a healthy A1C was. And so we spent a lot of time with the PCP from Salute joining our staff meetings and just talking about, well, let's do a little training on management of diabetes and controlling A1C, and why is that important, and how do you have those conversations. And I would say the last thing is that we have really pivoted towards our nursing staff becoming way more involved in follow-up conversations and follow-up visits to do things like diabetes education and blood pressure management education, and doing the kinds of things that again will help our consumers be healthier. And the side effect of that is our nurses are happier. They feel like they're doing more than just vitals and those kinds of things, is that they have an opportunity for face-to-face and one-on-one engagement around health issues with our consumers. And so that has been very successful, and again came from our learnings from this project.
So that was great. And I love that you mentioned the nurses being happier, because it really points to us thinking about the quadruple aim, right? No, not the triple aim anymore, but how does doing integrated care and other work that we do to advance community mental health, how do we look at it from the standpoint of workforce and provider happiness? Thank you. All right, folks, another reminder, go ahead and put any questions into the chat box if you have them. And JC, if you are ready, I'm going to call on you next. JC, I'm seeing you, but it looks like you're still muted.
Thank you. Got it. Better?
Great.
Okay. Southeast was a little bit unique position in the sense that we've been doing primary care for a couple years prior to this initiative. But what we were experiencing was growing patient panels, but a continual loss in revenue. And as the panels grew, the services grew, we continue to see the separation in cost and revenue we're basically not keeping up with each other. So we were given permission to handpick our practice facilitator, and that was an RN named Kristen Suiters with High Plains Research Network. And she works under the Department of Family Medicine for the University of Colorado, and we've worked with her on several projects over the last 5 years. And she specializes in rural and frontier communities. And when we started embedding her in our operations, there were several things she immediately recognized. And one was we were having workflow problems, and those have got away from us, where we thought we were doing primary care visits with complex behavioral health patients that were 30 to 45 minutes, and they were actually 45 minutes going on to an hour and 15 minutes. And we were only seeing 4 to 5 patients a day because you would have 1 or 2 no-shows. What we also realized is that our billing department was doing the best they could based on their knowledge. And what I mean is they were used to billing through capitated systems. And billing primary care fee-for-service and having to negotiate rates and do that on an annual basis, which we weren't even doing. We weren't even negotiating rates annually. We'd signed an initial contract and kept the contracts just renewing year after year after year. We saw that we had an education problem. We didn't have a certified biller or coder on staff. So we contracted one to come in, and with the help of our practice facilitator, we took a patient from the time of phone call all the way through service and billing and reconciliation, and found that even our front desk wasn't collecting copays. They didn't understand how that system worked either because they were used to the OBHO capitation system. You know, do they have Medicaid? Yep, okay, we're good, let them in. So even some Medicaid copays weren't being picked up. Obviously, the third-party payer stuff was a mess. We just didn't know what we didn't know. And the more we dug, the more we found we were doing so many things wrong on the backside. What we did do then is we hired a certified biller and coder that came in and was able to go back and collect a significant amount of revenue we missed, 6 digits or 6-figure revenue loss. And so that shored us up on the backside. We started to work on our workflows from the time of the phone call for services all the way through the billing component. We visited with our providers about length with patients, and maybe they were bundling services in those visits too much and trying to fix too many issues or address too many concerns, and that's what was causing these longer sessions, and that maybe we need to limit 2 conditions per visit and then schedule for a week or 2-week follow-up to deal with any other potential issues. So we had to kind of learn to triage those levels of importance. As we moved on, started figuring that stuff out, we also realized that we needed to shrink our panels to focus on persons in our organization that are here for behavioral health services and not be open to the community for just primary care only. So we went from about 1,200 patients down to about 400 patients, and the criteria was if you were receiving behavioral health in-house, you were eligible for primary care should you choose. And so all of a sudden now it created teams around these complex issues because everybody that was on the panel was shared within the organization. And that created conversations we couldn't just get to happen on a regular basis, where there were patients coming in from the community that had no behavioral issues. So our flow was kind of wonky. It wasn't consistent. There wasn't a lot of consistent communication within departments. But now that everybody was open for behavioral health, it naturally created these teams and these conversations we'd hoped for. One of the other things that helped strengthen it is our nurse practitioners started running chronic health condition groups. And so those patients that were coming in on a regular basis let's say were complex. In the primary care world, you'd call them non-compliant. What we were able to do is now form groups of patients that had similar conditions, and that was freeing up now more spots in the primary care provider's work schedule. So just like with behavioral health, we were finding commonalities and building groups. That became so successful, we actually hired 3 RNs, and now 50% of their work week is running chronic health condition groups of behavioral health clients, as well as medication management groups. And again, now you're starting to see the behavioral health side and the primary care side working much more collaboratively. So we are starting to see some really good outcomes. Another big part of our process was taking the CMS risk stratification tool for primary care and overlaying behavioral health symptoms and clients in that CMS stratification tool. So now we have a model in-house where anybody that comes in, whether it be physical therapy, behavioral health, primary care, they're assigned a risk level 1 to 6. And within those risk levels are established best practice contacts that actually are clinical providers designed around those risks, saying this patient would likely best respond around these interventions. And it was not an administrative tool because we wanted to be driven by providers. We took a year's worth of data and then were able to design those 6 levels. The intent of those 6 levels obviously is to make sure, one, that providers don't get too many complex, let's say level 5, level 6 on their caseload. So we don't burn out providers too much with too many complex cases that they get assigned. We can look at how many have 3s, 4s, 5s, 6s. We can look at those providers that actually do really, really well and see high performance on level 5s, and maybe they would choose to have a lower caseload with people that need higher intensity. So they can be assigned more complex patients should they choose. The other piece of that is we were hoping at this point in time, moving to ACC 2.0, whatever we're calling it, that we would be able to take the risk stratification model and build a value-based payment system and say, after 2 years of data, a patient in level 3, we have found runs about this much to the system. But unfortunately, I think we're a little bit ahead of the curve there. And so our stratification tool, other than for clinical need, is not being used for value-based conversations. I'm hoping that we're not too far away from that. So that's where Southeast has come. Like I said, we really had to dismantle our primary care program and start from scratch. And I credit our practice facilitator, again, Kristen Seuss with HPRN, about taking us back to the basics, bringing in a physical health lens as an trained RN, and then understanding that the back office work of physical health is so much different than the back office work of a capitated system. So that's what I have, Mindy. Thank you.
Stacey, thank you. That was great. And I really appreciate you talking about the business side of all of this, because I think that that's part of all of these lessons learned is really how do you develop a business model while you're simultaneously developing this clinical model and administrative processes. All right, Shannon, last but certainly not least, are you ready for us?
I am ready. So I wanted to kind of give you an overview of our health home because it was a little bit different. We had been doing integrated care and SPMI patients for probably 4 or 5 years when we started the SIM grant. So we really wanted to move it into child and family work. And so we had health coaches, we had behavioral health professionals in the office, in the primary care office. We partnered with our FQHC, who developed a clinic in one of our clinics. So they had a full clinic in one of our clinics with a nurse midwife, a pediatric nurse practitioner, and a primary care physician or nurse practitioner, depending on where we were in the grant. And then we had our full behavioral health team also. So we had child and adolescent clinicians, early child clinicians. We had transition clinicians who were working on late adolescence, early adulthood. We had supported employment. We had a navigation specialists. So just everybody, anyone we could think of, we put in the mix, as well as adult clinicians to work with parents and older adults who might come to the clinic. And a lot of our focus really was on whole family health. And we wanted to make sure that each child had the best start in life that they could. And a lot of that theory or thought came out of the AIMS studies and looking at the health risks as well as behavioral health risks associated with early childhood trauma, as well as social determinants of health. And so we focused on healthy relationships for the parents. We focused on healthy relationships in adolescents. We focused on preventing child abuse, childhood trauma. We screened moms for depression, but we also screened dads for depression. And really tried to give that child the best start in life to prevent anxiety, depression, as well as other chronic illnesses later in life. So, looking back, what impact did that have? And one thing looking back on this that we did show was that we were seeing a downward trend, just as Mindy had shown, in our high utilizers and our moderate utilizers, more to our low level of utilization in our children and families. And I think that was really significant. I think if we'd had more time, we could have shown a bigger trend, because by the time, you get the grant and everything gets going, I think we didn't have as much time to really look at that as we would have liked. I think one thing that was really significant for me in terms of what we learned is the importance of screening and risk assessment in our families, not just in the child themselves, but in the entire family, and looking at social determinants of health and really what we can do to make that family the best possible family they can be, and the best version of them as a family that they can be. We worked on substance use prevention early on, and I talk about in substance use prevention and screening, and I talk a lot about screening, and I think screening is hugely important. I think we don't make the space for screening, and we sometimes with behavioral health screens, we hang our head and say, it's something we got to do, or it's something that something that we have to sneak in, rather than making the space for that. We never say that about an MRI. We never say that about a CT scan. We never say that about a blood draw. A blood draw takes 10 minutes. And a PHQ-9 takes 5 to 10 minutes. And so why do we apologize or not make the space for a PHQ-9, but we make the space for a blood draw? They're both screening exams. And so I think it's really important for us to make that space for behavioral health screening. And that's one thing I really learned through this process. And that helps us in our trend toward prevention. A lot of times we talk about prevention, but prevention isn't just treating depression when we first see it. Prevention is preventing depression from the very beginning by teaching healthy relationship skills, teaching healthy coping skills, resiliency. So I think the other thing that was a big impact was the education to the primary care clinic. And often primary care clinicians just, they want to whip through their clients, they want to deal with the next problem and give a prescription or send them to physical therapy and move on. And really working with that whole family and knowing the complex families and the frustrations with that and teaching them how to deal with the complexity of that was a big education. We had some skeptics when we started and true believers when we ended. And I think that's hugely important. The other thing I think that we learned, and another thing that was important, was the alternative payment models and really looking at different ways to fund this. Funding integration is always difficult, but we've learned some creative ways to do it, working through the primary care clinic, as well as looking at other models like the COCM codes and things like that. So I think that was part of what we also learned is, trying to find creative ways to fund integration. So, and so the next question that many ask what's happened next? What have we sustained? And that's a good question. Unfortunately, as one of my managers says, and then COVID hit. And as COVID hit, we had a decrease in our number of clinicians in the clinic. And then COVID hit, and our primary care partner elected not to continue them in the clinic. So right now, we don't have an integrated model with our FQHC. However, we have sustained integration. So we continue to work with other primary care partners on integration and screening and whole family health, as well as SPMI clients, treatment-resistant depression, anxiety, which a lot of primary care partners see, substance use in their clinics, things like that. And so I think what we've learned from SIM has been sustained, even if it hasn't been sustained in the same way that we saw it initially. So what's the future? And how do community mental health centers fit into the future? And I think that's a big question. It's a broad question. I think community mental health centers, when we look at the resources that they have, the breadth of knowledge that they have, and the personnel resources that they have, they need to be key and integral to integration. I think they also need to be part of our public health. And one thing that SIM taught me was the importance of thinking of integration as public health. And it really is public health. And so using our community mental health centers as resources where we already have therapists, we have supervisors who can do clinical supervision, who can oversee these therapists, we have abilities for trainings, we have substance use disorders treatment set up, we have trauma-informed care set up, trauma treatment, we have a whole breadth of knowledge as well as services available. We have wellness services, we have all kinds of things available to our primary care partners. And I think that looks much different when we're working with integration than putting one therapist in a primary care practice. And when you put one therapist who may be strong in substance use or might be strong in early childhood in a primary care practice, it limits you. Whereas if you work with a mental health center where they have a breadth of knowledge, where that clinician can get supervision on lots of different issues, where they have a public health focus, that looks different than it does if you just plop a behavioral health clinician in a primary care practice. And I think people sometimes think that integration is simple, that it's just putting behavioral health into primary care, and it's not. There's a whole philosophy around it, there's a whole set of knowledge around it, and there's a whole set of skills around it that are different. And screening and risk assessment are really important. So
that's great, Shannon. I think you've really put your finger on a lot of the cultural issues that providers experience as they're working to integrate care. Thank you.
You're welcome.
All right, folks, so we've got about 10 minutes for some Q&A, and I know that Liz put forward a question directed at JC, but I'm sure if anyone else can pitch into this as well, you're welcome to. So Liz asked, JC, is your primary care side paying for itself now?
That's a very clear yes and no. So what we've done is, if you factor in, Liz, the amount of work they're doing running behavioral health, chronic health condition groups and billing the behavioral health side of the world, and you count that kind of toward their revenue on their primary care costs, there is a margin there. So if I just ran a PC practice and they weren't trying to do any integrated care and billing behavioral health units, it would not work. Does that help? Okay.
Yeah, that's exactly. Oops, sorry. Getting a little echo because I was on 2 devices. Hang on a sec. JC, I remember one of our last conversations about the program. You were having trouble with it being upside down on the primary care side, and I was really interested in what Kristen helped you do as in your transformation process and what ultimately made a difference. And it sounds like, you know, that to make it work, it truly has to be integrated, and you have to be billing what you can from whichever side to make those more primary care specialists like your nursing staff find a way to pay for them. So good to know. That's helpful.
Right.
Thank you.
I could tell you, you know, just roughly speaking, she took us from about a $300,000 loss annually per provider pair to about 100. So we were able to shore up almost 70% of our loss with her help, looking at flow and billing efficiencies and training. But the gap we just couldn't close after 3 years, get any tighter. So that's when we embedded them more on the behavioral health side to close up that little piece.
Great, thank you.
Thank you both. All right, we've got a question from Lindy Lewis, and she's asking everyone, how critical is having one shared medical record with access for the entire integrated care team to the success of an integrated practice? Anyone want to take that?
Andy, I'll take that if everybody's okay with that. You know, I think that's not the real world. I think if you work in one system, you know, again, either with one BHP in the system, or you work in an FQHC or another system that's fully integrated, that's fine, and you can do that. However, the reality is, particularly as community mental health centers, if you're working in multiple systems, it's difficult to get into. You're not going to have one EHR because every system is going to have a different EHR. And so then how do you get around that? And some of that's with contracts, some of that's with payment models, and some of that's with double documenting, which is always a pain. I think it's good communication, though, no matter what you do. We've had healthcare coordinators who their sole focus is to keep communication flowing between primary care physicians and the psychiatrist and the whole mental health team. So I think as long as you have good communication, it's not absolutely essential.
And I just dropped a note in the chat that read-only access helped. It took a long time and a lot of discussion to figure out how to make that work. But read-only access helps. We also got around that by printing things, schedules for each day. We had front desk staff from Clinica and MHP working together to prep the daily huddles from each EHR. So we did a lot of workarounds and manage.
Great, thank you, Shannon and Sarah. We have a question, I'm not sure whose email this is, but the question is, how do you incorporate your psychiatrist into the integrated care model? Anyone want to jump in on that one?
I can quickly say, I know ours is quick, and then Shannon, I see are off mute too. We had one psychiatrist devoted to the team, and he basically joined as a consultative sort of model. And then what we tried to do was wrap the workflow around him as sort of the primary care physician equivalent on the behavioral health side. So we would look at his schedule to try to manage daily huddle, who was coming in to see him and who might need a primary care physical health touch, and that sort of thing. So kind of looking at his caseload and how we could integrate primary care needs for those clients as they came in. And then a lot of consultation with primary care physicians.
We had a little bit of a different model. We had a weekly team meeting where we had all of our psychiatrists on that team meeting with the primary care physicians, as well as, again, therapists and anybody else involved in these cases. And so that gave them an opportunity to touch base about difficult cases on a consistent basis. I think that's kind of one model. It's a labor intensive and expensive model, but it worked well. And even with that model, we wound up saving money. That said, I think another way you can do that is through the COCM codes. We're looking into the consult codes to see if we can use those also.
I just had a follow up, and that question was for me, Juan, over at Aspen Point. I'm curious as well as a follow up. Do you have your primary care providers manage the more stable clients that are on psychotropics so that it relieves the pressure from the psychiatrist?
Trying to, we didn't. In our SPMI clinic, we didn't, because most of them were pretty severe. These were our severe SPMI case management clients, and so we didn't generally. We do sometimes refer back to primary care if somebody's stable, and I think it's not a bad model at all. I think you can use the COCM codes with that if you choose, and that way you can have the primary care manage them, but then the psychiatrist is consulting on a weekly basis, and you can see more people that way.
And in case anyone's not aware, the COCM codes are the collaborative care management codes that Shannon was referring to. There was a comment from Rick Doherty from MHCD. I know he's not on the phone anymore, but it's a great comment, so just want to make sure everyone saw it, about that he's hoping that we can hear more about how integrated models can be used to create equitable access to care for populations who have experienced disparate health outcomes, including people of color and people with disabilities, including those who are deaf and hard of hearing. I don't know if any of the presenters want to respond back to that, even though Rick's not on the phone anymore. Anything, any reactions to that?
I mean, yes. And I think one of the benefits of the integrated health home model is the individualized care and that kind of ability and commitment to bring care out to clients. So that kind of extra capacity to do outreach and address barriers with folks. They have a little bit of a different capacity and team ability to address barriers like needs for translation, ASL, that sort of thing. There's a whole lot more to learn and progress to make, but there is something about the multidisciplinary team kind of individualized care approach that does allow for some more creative problem solving to address barriers, whether they be things like translation, language assistance, or transportation, food security, that type of thing.
Go ahead, Jill.
I was also just going to add that one of the things, we have a consumer advisory panel, and issues around equity and access are hot issues with our consumer advisory panel. And I think they've been super helpful to us in giving us feedback about the way we provide services, the way we engage people, that I think have improved our how accessible we are to a variety of people. And I think that, again, one of the other things that came from SIM was we called it the patient advisory panel through SIM, and we call it the consumer advisory panel on the now that it's just community reach, and that was a very helpful idea to really bring forward the voice of our consumers, and in particular to really recruit a variety of individuals and really kind of capture their voice and their opinions. And I think that has been a very valuable process that we have and that we continue to utilize.
Great. Well, we are at our time. That hour just flew by. I know JC added a comment into the comment box that they use mid-levels for 80% of their psychiatric med management services. I want to thank all of our presenters, Sarah, Jill, JC, Shannon. We just are so appreciative of your time and your expertise. If anyone has any follow-up questions, please feel free to contact me. And this session was recorded, so we will be able to share it with more of our membership. Thank you, everyone. Stay well. Take care.